Okay, I think that we'll go ahead and get started. My name is Heidi Melbostad. I am a postdoc here at the University of Vermont. Thank you all for joining us on this second poster session today that's focused on improving treatment. I'm joined today by Dr. Kelly Peck, who is an assistant professor also at the University of Vermont. So just to review, everyone will have 5 minutes to present their research. If anyone has then any clarifying questions after each presentation, feel free to ask, but then we'll have a general discussion at the end when everyone finishes. So first up today is Anthony Eller from Yale University. So Anthony, if you want to go ahead and share your screen.
Yes. Let's see. Can y'all see that?
Yep.
Put it in the slideshow. Okay. Everyone, I'm Anthony Eller, and I'm the project coordinator for this HRSA funded project titled Strengthening Systems of Care for People with OUD and HIV. It's under the direction of Drs. Altice and Madden. And so everyone knows or is aware of that there are a multitude of factors that really undermine the successful coordination of HIV and OUD services. And what are we doing to combat this issue? We're collaborating across 2 regions and 5 states, Maine, Connecticut, West Virginia, Kentucky, and Vermont, and utilizing the Learning Collaborative Framework as well as a NITEX Treatment Improvement Model Implementation Science Framework with 2 primary aims. 1, to scale up medications for opioid use disorder, and 2, to integrate those OUD services into HIV and HCV prevention and treatment services. Considering the data really suggests that scaling up MOUD is the most cost-effective primary prevention strategy and is a good predictor for ID or infectious disease treatment, we see the combining of those 2 aims as being the most promising solution towards addressing this endemic or these dual and emerging epidemics we have going on. How we're going about that, the methods is simply 4 steps. We've conducted a needs assessment or a gap analysis in which we're identifying opportunities, looking at the epidemiological landscape, the legal framework, as well as policy and funding analysis to see where there are gaps in treatment. Secondly, we've assessed or assembled together some key state-level stakeholders to identify those gaps in our findings and really guide the project within their state. Third is establishing those learning collaboratives to really implement those change projects around those gaps that we've identified in the gap analysis and to really push the project forward using that NITEX treatment framework. And 4, hopefully, which we're just in year 2 of the project, but we'll get to is sharing those promising practices, good or bad, from what we've learned through the implementation of these change projects. So a little bit about the results and opportunities. I'll just go through a couple of them. First and foremost, the need is here. The overdose fatalities are on the rise, and vulnerability for HIV and HCV outbreaks is worsening, as you're all aware. So that's an urgent problem that is in need of understanding best these strategies. There's legal impediments that across states that are preventing the scale up of evidence-based services, whether that's in corrections or within treatment facilities. It varies across sites. And there's also as well another finding is varied testing and retesting procedures for OUD, HIV, HCV, and what we're finding is a lack of standardized protocols across sites. And lastly, I think most importantly, what we've come to find is we do have a really well-developed HIV continuum of care, but for one of the primary outcomes for this project is we're hoping to develop an analogous continuum of care for OUD as well. And that's where we're having difficulty and just on a given day, being able to identify how many individuals are on medications for opioid use disorder and seeing that as being an important piece to really targeting interventions understanding, okay, where is the need and where we need to be providing these services. And just a couple of the conclusions that we found through this preliminary analysis is there's major opportunities for increased induction into MOUD across multiple touch points. So whether that be in DOC or within the ED or FQHCs and reentry, there's major opportunities for increased induction. Second point, identification. There's a need for standard operating procedures for co-screening, co-treatment of OUD, HIV, HCV, as well as PrEP readiness. Really braiding those pieces comes in. I mean, it seems from what we found that every site is doing it, but doing it in a different way. If there's a way that we could operationalize or standardize those procedures, thinking that that could be very helpful. And lastly, back to the data collection piece, there's an opportunity to really improve the data collection and availability across sites. As I mentioned, without it, it's really hard to assess the needs in the area, and is a major impediment to addressing these emerging epidemics. So that's quickly what we've been doing the past year. So thanks.
Great, thanks very much, Anthony. Does anyone have any clarifying questions at this time? Okay, I think we'll move on then. So Anthony, if you want to stop sharing your screen, and then our next speaker this afternoon is Nathan Moxley-Kelly, who is at the University of Vermont.
Hello, everybody. Okay, so I just need to pull up my poster. Can you all see that?
Yes.
Okay, awesome. So as Heidi said, my name's Nathan, and today I'm presenting a preliminary study that investigated the effects of attendance-based monetary incentives to improve attendance to exposure therapy in individuals who have concurrent opiate use disorder and post-traumatic stress disorder, PTSD. So as you all know, opiate use disorder is highly prevalent in the United States, and moreover, roughly 1 in 3 individuals with OUD have concurrent post-traumatic stress disorder. Although opiate agonist treatments such as buprenorphine and methadone are highly effective for treating OUD, those with concurrent PTSD tend to fare worse than those without. So prolonged exposure therapy is an effective treatment for PTSD. However, its effectiveness is limited by poor attendance. So this study investigated the effect of monetary incentives to improve attendance to exposure therapy in individuals with that concurrent opiate use disorder and post-traumatic stress disorder. Okay, so how did we do that? Well, we sampled participants who were adults and who were currently maintained on methadone or buprenorphine and had concurrent post-traumatic stress disorder. We divided these people into 3 groups. So the first group was just maintained on their buprenorphine or methadone as given to them by their provider. And the second group were also continued on their buprenorphine or methadone, but additionally had access to up to 12 sessions of prolonged exposure therapy. The third and final group were maintained on the buprenorphine or methadone. They had access to the prolonged exposure therapy, but in addition, they received monetary incentives to actually attend their exposure therapy sessions. So if you look at the table to the right there, this depicts the incentive schedule. As you can see, for the first session, the person received $20, and then for each consecutive session that they attended afterward, there's a $5 increase. So second session, 25, third, 30, and they, in addition, received a $50 bonus. So this schedule is designed to really encourage people to attend all of their sessions. In addition, everyone was followed up at 4, 8, and 12 weeks. So a little bit about prolonged exposure therapy. This is an empirically supported and first-line treatment for post-traumatic stress disorder. It's designed to disrupt the cycle of anxiety and avoidance that characterizes PTSD by deliberately and systematically exposing these individuals to previously avoided memories. Okay, so We hypothesized that the incentives would improve attendance to prolonged exposure therapy, and we compared the group that received the incentives to those that did not. And what did we find? Well, first of all, the sample was predominantly female, middle-aged, and had been using opiates for 7.8 years, daily or almost daily on average. They'd additionally been receiving OAT or buprenorphine or methadone for an average of 5.2 years, so quite stable on those medications. So I'll draw your attention to the graph on the left, bottom left there first. So this depicts the follow-up appointments attended by each of the three groups. There's no significant difference in the percentage of follow-up appointments that these groups are attending, suggesting that all of the three groups are adhering to the protocol and willing to come in to speak to us to get reassessed. Now, you can contrast that to the second graph there on the right, which depicts the two groups that had access to prolonged exposure therapy. The bar on the left depicts those individuals who just had access, and the bar on the right, those individuals who had access to prolonged exposure therapy, and in addition, received incentives to actually attend their sessions. Comparing these two groups, those that had the incentives attended significantly more of their PET sessions. So that's what we wanted to see. In conclusion, the greatest limitation to the use of PET for PTSD in individuals with substance use disorders is attendance. And the present findings, they extend previous research that has shown that incentives work to improve attendance to psychotherapy. More specifically, incentives may represent a means to improve exposure therapy attendance and thus outcomes in this high-risk and vulnerable population that has comorbid opioid use disorder and post-traumatic stress disorder. Furthermore, as rural populations face significant barriers to treatment, such as having to travel great distances or maybe financial barriers, these incentives may be particularly pertinent within that population. Thank you.
Great, thank you so much, Nathan. If anyone has any clarifying questions, otherwise I think we'll move on to the next speaker. So our next presenter is Mitchell Garrett from the University of Utah.
Oh, let me share my screen.
Great.
Okay. Can you all see my poster?
Yes.
Cool, awesome. So hi everyone, I'm Mitchell Garrett. I'm happy to be here with all of you today. I'm a research analyst at the University of Utah Program of Addiction Research, Clinical Care, Knowledge, and Advocacy within the Division of Epidemiology. I'm also a graduate student within the University of Utah's College of Social Work. So today I'll just be discussing a secondary analysis of a patient-provider intervention study. Myself and the other authors examined stigma related to opioid use disorder, or OUD, and barriers to pregnancy care and treatment in rural communities. This study was led by our principal investigators, Dr. Gerald Cochran, Dr. Marcella Smid, and our amazing research team. And this project was supported by a grant from the Utah Division of Substance Abuse and Mental Health. So starting with methods, we implemented several interventions in hopes of enhancing prenatal care. So provider education and resource enrichment was delivered in 2 rural Utah counties that actually lead the state in OUD-related deaths. And provider education included numerous webinars facilitated by cross-discipline experts. And resource enrichment included tailored case management services and collaboration with already existing resources in the communities. So with the secondary analysis, the other authors and myself, we wanted to see if the interventions could possibly lead to a decrease in provider and community level stigma in rural spaces. Still in methods, but to assess community changes in stigma, we used a purposive sampling design. I'm a little nervous. We conducted 16 qualitative interviews with local county healthcare providers and community stakeholders. We did this twice throughout the study period, at mid-implementation and post. We did do a pre-interviews, but that's kind of where we were just evaluating how things were. And then we evaluated improvements in the mid and post. So interview questions were designed following the CFER method, so the Consolidated Framework for implementation research. All interviews were double coded by our team using in vivo 12 and the RITA method. Coding frequencies and agreements can be seen here on the table, on the two tables. Agreements were found not to be lower than 93%, which indicates near perfect agreement, and our kappa scores were found to range from fair to nearly perfect. So kind of confirmed through the interviews and other results, our project interventions were successful in decreasing negative attitudes and perceptions expressed towards people with addictions. It helped with fear of criminalization or child separation, stigma associated with substance use, and expressed hope for ways of treating OUD in pregnancy. So we're just hopeful that addressing access and treatment quality through healthcare and other community channels could have that important influence. Under continued results, we did get some quotes. Some of those are from community stakeholders and providers, but that's what we were looking at. And we're actually going to be moving into another very southern Utah, rural, like Four Corners area county, to kind of see if we can implement this and other things down there. So I don't know, it's pretty exciting.
Great, thank you so much. Okay. If anyone has any clarifying questions, otherwise we're going to move on to our last presenter today. Okay, so our last presenter today is Dr. Chris Brady, who unfortunately was not able to be here in person, so to speak, on Zoom, but he did send us a recorded presentation, so I will share that with you right now. And Chris is, if I didn't mention, he's at the University of Vermont. He is a physician and assistant professor at the Lerner College of Medicine. Okay, can everyone see this? Great.
For your interest in our project on cost effectiveness of diabetic retinopathy screening. Diabetic retinopathy is the leading cause of vision loss in working age individuals. However, when identified, treatments are effective and cost effective. Therefore, screening asymptomatic individuals is effective and cost effective, but screening rates are quite poor nationwide, ranging from something like 20% up to 60%, depending on the study. And this is particularly acute in rural areas with low density of eye care providers. In our region, diabetes prevalence is lowest in our most populous counties, whereas access to eye care providers is highest in our most populous counties. Likewise, there are only 5 retina surgeons in the state of Vermont, and these are likewise concentrated here in Chittenden County, and these are the providers that end up treating the most severe complications of diabetic retinopathy. So we partnered with 2 rural primary care offices about an hour south of here, where we installed a non-dilated fundus camera where we can take retinal images and screen patients for diabetic damage in their primary care office at the time of their consultation for their medical situation. The purpose of the study here is to explore whether teleretinal screening can be cost effective compared to live examination, the traditional standard of care, using a decision tree analysis. We know that the use of teleretinal screening increases retinopathy screening rates and reduces vision loss. However, the question is whether it remains cost effective now that the management of diabetic retinopathy has become so expensive. For this study, we compared teleretinal screening and live screening using a decision tree analysis with Triage Pro software. We used the disability weight of vision impairment and a 1-year direct medical cost to estimate the costs of both methods. We performed a Monte Carlo simulation with 100,000 trials to explore the uncertainty of our estimates, and we looked at the incremental cost and the probability that teleretinal screening is cost effective. We also looked at some one-way sensitivity analyses to see the cut point at which point teleretinal screening becomes cost effective or cost saving. Including all potential outcomes and treatments, the average cost per person is $230 in the teleretinal screening intervention compared with almost $300 in the live screening. Therefore, an average teleretinal screening saves $62 compared to the live screen and is cost saving in 98% of the trials in our simulation. The average disability weighted outcome was basically the same in each group, showing that there's no decrement in quality with the cheaper intervention. When we hold all the other variables constant, the teleretinal screening group had a lower average cost per person when the cost of screening is less than $120. This is a graphical representation of our decision tree, and you can see how the teleretinal screen group and the live screen group essentially follow the same path with the outcome of the screening and then the outcome of their disease state. Likewise, this is a graphical representation of some of the data that I just mentioned, which shows on the left-hand side of your screen that the numbers are negative on the x-axis for 98% of trials, which means that for the vast majority of time, teleretinal screening is cost-saving compared with live examination in our decision tree, and this is largely driven by the cost of the teleretinal screening being cheaper. Likewise, we found that as the cost of teleretinal screening increases, it remains cost-saving until a threshold of approximately $120. So in conclusion, teleretinal screening was cost-saving and equally effective compared to live screening, as I mentioned, largely driven by the lower cost. In an ACO, we're responsible for the patient experience of care, which we believe is improved by teleretinal screening since they don't need to attend a second live examination, which is particularly valuable in the time of COVID-19 pandemic. But this is somewhat difficult to quantify in a decision tree analysis, which really only allows us to look at cost and some measure of effectiveness and doesn't allow us a third dimension. So we look forward to further characterizing both indirect and long-term costs, which our model also did not allow us to explore. So here's the full poster that you can peruse, and I regret that I was not able to be here in person, but I look forward to engaging with you via email if you choose. Thank you.
Okay, great. So we're all finished with the presenters at this time. So we'll have a discussion now with either Anthony, Nathan, or Mitchell. Either if you want to just unmute yourself and ask a question, or feel free to use chat. And then if you do have any questions for Dr. Chris Brady, please put them in the chat and we can pass them along to him. So Anthony, I have a question regarding the research that you're doing right now, and wanted to know, given your focus on implementation, how COVID has changed the research that you're doing, if you're taking that into account at all, or how you're addressing the really marked changes in care that we've experienced because of the pandemic.
Yeah, definitely. That's something that we're taking into consideration. We've created a survey to assess providers and how, and each of the sites or the states that we're working with to assess how COVID is impacting their treatment. And as we've had to move remotely, and this was kind of in the beginning of the project, that's kind of pushed our timelines back a little bit. But things are back to normalizing somewhat, as in we're able to meet with people virtually. But yeah, we're trying to assess how providers are dealing and how it's impacting their treatment facilities. So it's definitely having an impact.
Well, it's great that you're able to survey them and take that hopefully into consideration going forward.
I also had a question for Dr. if I can jump in. You mentioned that you identified a number of places where could be good places to insert induction for OUD. And we've looked at some data from a project that we're doing where we found a surprisingly high rate of providers who don't really believe in maintenance treatment, that still kind of question the efficacy of it, and which really blew me away. And I'm just curious, in the different, you've got multiple sites and you're talking with people in multiple different areas. Are you getting much of that as well? Am I ridiculously naive?
You're accurate to assume that. Yeah, it's definitely varied across sites, but that's been one of the first things that we've been working on is actually around provider education, not just with clinicians, but also with working with harm reductionists, recovery coaches. We've been doing some effectiveness of MOUD trainings, really just a true and false dispelling myths thing that we've really had to our surprise as well, that's something that needs to happen is more education around that. So that's another project that was from our results that I wasn't able to point out, but it's definitely a big piece to it. So
thanks.
And along those same lines, Mitchell, I'd be curious to know more about how in Utah and in your area with prenatal care, how MOUD and medication treatment, what is that a standard of care? Is that an option that's provided to women? And then what does the care look like for them? Is it integrated services of prenatal care and substance use treatment, or are women having to go to multiple providers to get their care?
That's pretty tough, especially with rural Utah, because Utah's a big state and we only have like one big city, Salt Lake, and that's not even that big, we find that in Salt Lake, there's a lot of opportunity for MOUD in pregnancy. And a lot of clinicians can have that conversation because there's a lot of fear of, is this gonna harm my baby? Is this gonna harm me? And so before we kind of went down there, a lot of women were coming like trekking a 2 or 3 hour drive up to Salt Lake. But Price is the city that we were in. So there were some providers in Price around it and around just the education of a lot of clinicians didn't know that it like Suboxone or Subutex has been seen through research to be fairly safe for a baby. So I think there's a lot of that going on, but yeah. So yeah, it's getting there. It's helpful.
Yeah, I think talking about provider stigma, I think that's really interesting work and such an interesting topic, just because I guess in my like little research world bubble, I'm always thinking about stigma in the community that serves as a barrier towards, like, I don't want my friends and my family to know that I'm taking these medications. And I guess sometimes I forget about like provider stigma and what a big barrier that could be. And so what you're seeing is in this research work that you're doing in Utah, just by providing healthcare providers with education and some additional resources, you start to see their attitudes change. Am I following you there?
Yeah, definitely. And that wasn't even it's a secondary now. That wasn't even our primary, and we were just really excited to see that that things were changing essentially. But there was always that question of how do we keep it sustainable, because a webinar, we're all engaged, and then we can log off, so we had a lot of conversations around how can we keep this sustainable. And in this small town, there's only 3 OBs and they all share one ultrasound machine, so there's a lot of conversation around, they all influence one another, so we really had to make sure we were working with everybody, like all the clinicians, or it wouldn't have worked, so we got really lucky that it was really collaborative in that way. So
I feel
Very cool.
it also extends, it is, yes, it's the providers initially, but it's also the front desk staff and the rooming staff and everybody in a practice so that the patient doesn't feel stigmatized when they walk in. So I think it's about reducing stigma for everybody all around. Definitely. I don't know how we address that.
Mm-hmm. And when I said providers, we were also with peer support specialists, social workers, clinical staff, MAs. So we were mindful to integrate everybody in there that we could.
Yeah, and to piggyback off of that, Martha, and what we're seeing is how that kind of snowballs, from within the clinic with people that are working in the clinic up to legislators and judges. I mean, what we're working with in West Virginia is we're planning to do some education of some judges because the policies that they're currently enacting that are really inhibiting scale up it leads up to that, and changing policies that really make it hard to start to get people on treatment. So it's really interesting.
I think that relates back to my question I don't know if you were in the other session, but about the waiver and whether it's helpful or not. I feel like buprenorphine is a very safe medication, and it's much safer than a lot of other things that I'm allowed to prescribe. So it's kind of odd. I mean, I understand why it's there, but from a safety perspective, it doesn't make sense.
Similar sentiment. Interesting.
I had another question. For Nathan and Kelly, your early data are looking really nice, and I'm assuming in addition to reporting outcomes like number of visits attended, that you'll also be looking at measures of PTSD. And I was just curious, how do you measure, how do you tell that someone has benefited from this exposure therapy?
Oh, Kelly, do you want to try and take that one? I feel like you're pretty well equipped for it.
I don't want to. This is your presentation, man. You take it. Have at it.
Okay, so there are a number of different measures that we use that assess for PTSD symptoms. For instance, there's a test called the CAPS, and we're following people up at 4, 8, and 12 weeks to see how they're doing in terms of their symptoms. Not sure, does that answer your question? Or Kelly, you have anything to add there?
Yes, it does.
Sure. Yeah. Yeah. And one of the interesting things is being at BCBH, where a lot of y'all are able to biochemically verify your primary outcomes. One of the interesting things with PTSD is that we rely on self-report. So as Nathan referenced, the CAPS it's a clinician administered post-traumatic stress scale. And so not only is it a mouthful, but it's also really intensive and difficult to administer, but it does give us a really good picture of how that person is doing. If we could develop a biochemical test for whether or not somebody has PTSD, that would be great. But often in a lot of psychological research, we're depending on self-report scores. We are also collecting some UA data to look at substance use over time as well.
And Nathan, I'm sorry if I missed this, but can you say a little bit about how you're recruiting participants for your study?
Oh, through a variety of means. We get a lot of participants through the buprenorphine and methadone dispensaries, the network here in Vermont, and we recruit through other medical offices. We advertise through a number of mediums online. So yeah, I mean, hopefully we're getting a wide variety and good sample that is a good approximation of what the population is actually like through those variety of means.
Thank you. We still have a little bit time left if anyone has any additional questions. Okay, well, if anyone's opposed, I think we can end here. Thank you all for attending, and thank you to the presenters for all your hard work and the research that you're doing.
Really nice work, everybody.
Thank you.
Thank you all.
Thank you.
Thanks, everyone.